पिछले ट्यूसडे क्लास हुई थी क्या आप लोगों की? क्या टॉपिक पे हुई थी? Because the first class was about basic anatomy of the breast. So your previous class, I think benign breast diseases might be have been covered. So the next important thing after benign diseases is the malignancy of the breast. So a person who has become a role model for the breast surgery is, if anybody knows who became a role model, a very famous Hollywood celebrity got her bilateral breast removed since she had a family history of CA breast. So prophylactically, she had them removed. Does anybody know her name? Angelina Jolie. So it is the most common cause of death in the middle-aged women in the Western countries, and since mostly it is involving the breast, the diagnosis nowadays have been become more easily, and due to awareness, the prognosis of has also improved a lot comparatively to the previous studies. Now, due to presence of different gene mapping and Now, due to presence of different gene mapping and hormonal assay, we can know about the prognosis and the therapy which has to be provided to the patient for a better outcome. Geographically, it is common in the Western countries, extremely rare below the age of 20, but few cases have been reported in which it is most common in the inflammatory breast carcinoma, which always starts at the stage 4B. In the classification, it has been mentioned as a separate entity. Gender less than 0% in males, but when it comes to male, the prognosis is bad, way bad comparatively to the female, since in the male breast tissue there is a lot and very less or depleted amount of fat tissue. So if there is any malignancy occurring in the male, it will directly spread to the pectoralis, muscle and fascia, which I have taught in the first class of this month. So the tumor already becomes in an advanced stage. From locally, it directly advances to the advanced stages by the time it is being diagnosed. Low photoestrogen diet, high alcohol intake, genetic factors, long-term HRT human replacement therapies, previous cases of radiation are also being causes of breast carcinoma. Other risk factors are early menarche. Early menarche is a risk. Age at first live birth. Lack of breastfeeding is a risk factor. Therefore, whenever there is a female lactating, it is advised to feed the baby as long as possible, which is not commonly performed in the Western countries. That's why the malignancy chances in Western countries are more. First degree related with breast cancer, carcinoma of the contralateral breast or endometrium, obesity in old ages, increase in estrogen levels, environmental toxins, and tobacco. Now, what are the genetic? Genetic mutation are the pro-oncogenes expression of HER2 receptors. You have to learn them, memorize them, anyway you have to learn them. When there is a question asked about the CA breast, you have to mention all these pathogenesis, these genetic factors. Mutation of the tumor suppressor gene BRCA1 and BRCA2 in breast endothelium and epithelium. Hormonal influence, endogenous and exogenous estrogen excess or hormone imbalance causes the mutation or genetic DNA damaging, which causes a free radical formation, and whenever there is a free radical formation, there is a chances of malignancy occurring. This is a different type of breast carcinoma. You can see in the first and foremost normal, if anybody remembers pathology book. In the normal is non-proliferative phase. When it changes to proliferative disease, then the atypical hyperplasia. Atypical always leads to malignancy transformation. Initially, it will perform into carcinoma in situ. Carcinoma in situ in TNM staging is always written as TIS. That means carcinoma in situ. You can't visualize it by hand, eyes. Clinically, you can't palpate the lesion, but there, in microscopic level, there is carcinoma. That is carcinoma in situ. Invasive carcinoma, word itself derives it. There is an invasion occurring by the breast tissue. Invasion can be not to the pectoral muscle or skin. It can be from lobules to the ductules. Now the germ cell mutation, the luminal loss of apoptosis, main cause, the cell forgets how to die. Genome instability, self-sufficient growth, limitless replication, which leads to tissue loss of growth inhibition. These all are the factors which leads to malignancy. Remember, whenever there is a malignancy in the body, anywhere possible, it is 99.999% painless and it will always be vascular. In local language say, the body doesn't treat the malignancy as a foreign object. It treats it as a part of the body. When the tumor requires a lot of nourishment, since the growth inhibition factors are not there, the tumor will grow at a higher very speed rate compared to the adjacent structure. So body will provide new vascularization, increase the vascularity of that tissue instead of killing it because it thinks it is a part of the body. So it will be painless. Only pain will occur in a case of malignancy when nerve or adjacent structures are getting involved. Their pain will be referred to as the tumor pain. The malignancy itself will never cause pain in any patient. Now, this is a different classification or the percentage of malignancy which we see. In situ carcinomas is both. In first class, I told you different. There is a lobular carcinoma and ductal carcinoma. Ductal carcinoma in situ, lobular carcinoma in situ. Then are the invasive carcinoma, no specific carcinoma, ductal, lobular carcinoma, cribriform carcinoma. These are classification when you send the specimen of the breast tissue for biopsy or you perform a true cut biopsy. This will decide which type of malignancy is performed and what is the prognosis. Plus the hormonal assay. Tubercular, mucinous, medullary carcinoma, papillary, metaplastic carcinoma. These are the different type of carcinomas in breast. And when the exam question comes, you have to mention these different type of malignancies. Now, how does the breast cancer spread? Because whenever there is malignancy, you should always know the way it will spread. By that, you will be able to perform the surgery if there is surgery possible. Whether if the tumor is spreading by lymphatics only, then you have to know which all lymph node you have to excise. If it by the bloodstream, you have to look for local metastasis in those organs to know whether it is an advanced stage carcinoma or a locally spread carcinoma or stage 1 or stage 2. Local spread to the skin, the pectoral muscle and even the chest wall if diagnosed late. Lymphatic spread is through primary to the axilla and the internal mammary lymph node. Bloodstream, skeletal metastasis, liver, lungs, brain, adrenal and ovaries. Now, clinical features. Found mostly in the upper outer quadrant. Does anybody remember what was the reason I said it is always present in the upper outer quadrant most commonly? Second point, discrete, painless, movable mass. Movable mass will be when it is initially diagnosed at an early stage of diagnosis. If it is adherent to the pectoral muscle, it will be having restricted movement, and if it is involving the skin or the Cooper's ligament, it will be mobile but not freely mobile. Will present as hard lump which may be associated with indwelling of the nipple. That means it has involved the lobules and ductules. Locally advanced cases, skin involvement with pudgy orange or frank ulceration or fixation to the chest wall. Now, whenever there is malignancy, there will always be a TNM classification. T0, no primary evidence of primary tumor. Does anybody know why the hell we write this T0 if it has no significance? Is there any staging in which you are writing patient present with CA breast T0 N1 M1? N is for lymphatics, M for metastasis. M is always either MO or M0 or M1. M0 means no metastasis, M1 means metastasis. So why is there T0 in all the TNM staging? अगर ये है ही नहीं तो इसको क्यों लिखा जाता है TNM classification? In every classification in TNM, if you have studied or remember by any chance, there is always T0 is no evidence of primary tumor. What does that mean? Sometimes the staging may be written as T0, N1, M0 or M1. If there is no primary tumor, then why there is N1 or M1? Find it in the net and tell me whenever possible in the next class. I will ask this question: what is the role of T0 if there is nothing in this particular line? TIS carcinoma in situ. T1 tumor less than 2 centimeter in the greatest dimension. T1 tumor is less than 1 millimeter in greatest dimension. T2 between 2 to 5 centimeter. T3 more than 5 centimeter. T4 tumor of any size with direct extension to the chest wall or the skin. Lymph nodes: N0 no palpable lymph node. N1 ipsilateral axillary lymph node palpable. N2 ipsilateral axillary lymph node palpable and fixed. N3 ipsilateral supraclavicular lymph node palpable. You have to memorize this classification and you have to write it. There is no mnemonic to learn it. You have to learn it by heart. M0 no metastasis. M1 distinct metastasis. T0 classification is written because in some patients, if in a case the malignancy part has been operated and the patient has came to you for follow-up with a case of recurrence, then you have to give the staging. The tumor has been removed, so T will be 0. That's why in T0 it is always written no evidence of primary tumor. N will be present because recurrence is happening, so N will be present. Lymphatic involvement was occurring in the recurrence. That's why T0 has to be there in TNM staging. समझ में आया नहीं आया लाइन? किसी के malignancy हुई, patient got operated, mass was removed, lymphatics were not touched, patient had some recurrence. Again you have to give the patient a staging TNM. But you can't give the T since the tumor has already been removed. For that, T0 has been advised and it is present in all the TNM classifications in all over the body. These are the different staging methods: T0A, TIS, NO, MO, T1A, T1, N0, M0, T1B, T0, M1, M0, T1, M0, M1, T2, T0, N1, M0, T1, T2 is also involved. T2B, T2 and T3 is N1 staging. T3A, you have to just know if you are performing for oncosurgery, you have to remember, basically you have to remember the TNM staging. In this T1, stage 1 and stage 2 are locally advanced breast carcinoma and after that is advanced breast carcinoma. This is the AGHS classification. In carcinoma in situ, lymph node status, no metastasis absent, it will the survival rate is 92%. This is the basic overview knowing what is the different survival rate with different type of metastasis. In which you can see in carcinoma in situ, after performing the surgery, when there is no metastasis or no lymph node, the survival of the patient is maximum. That's why early diagnosis of breast cancer is always beneficiary for the patient. Whereas if you see if there is any sort of invasive carcinoma in which skin and that part has been involved, due to since it has a lymphatic spread and blood spread, both are happening, the prognosis factor will be less. This is also prognostic factor calculator. Very low breast carcinoma, screening detected, TIS tubular or specific type, and treatment is local excision. breast conservative surgeries can also be present. This is the different topic is receptor status. These are to predict the response to hormonal therapies. After performing surgeries, the patient is always goes for chemotherapy or radiotherapy or hormonal therapy. To rule what type of response will be getting from it, you have to perform hormonal assay. Whenever the tumor is excised, it is sent for receptor study. To predict the response of immunotherapy, to predict the prognosis, hormonal receptor, estrogen receptor, progesterone receptors, and third is the HER2 receptors. What is HER2 receptor? It is membrane tyrosine kinase receptor and marker for cellular proliferation. Expression is up to 30%. Current assay of HER2 is by IHC stain and FISH. Now, after you knowing about the tumor markers, what are the different surgeries you have to perform? There is radical Hamslet mastectomy, modified radical Patty's mastectomy, simple mastectomy, and cancer surgery or BCS. Radical means excessive dissection. Nothing has to be left behind. You are not looking for a cosmetic result. Tumor has to be excised. This was a Times Now image. Removal of the breast tissue. What are the indications in total mastectomy? Large tumors, central tumors beneath the areola or nipple areola complex, multifocal diseases, local recurrence, or patient preferences. Patient preferences is also a thing in which the patient has a very strong family history with hormonal history suggestive of future chances of having breast cancer. Now, what is simple mastectomy? In the examiner will always ask you what is the difference between simple mastectomy, radical mastectomy. Simple mastectomy is removal of only breast tissue plus or minus regional on the axillary tail of breast. There is no dissection of the axilla. Only breast is removed. Why only breast is removed? Because you are removing the breast tissue before involvement of the axillary lymph nodes. Therefore, the breast metastasis will not be happening in the lymph node. There is a test to confirm whether there is lymph node involvement in it or not by simple. Which type of lymph node is present in CA breast? Sentinel lymph node. Then is radical Hamslet mastectomy, inclusion excision of the breast, axillary lymph nodes, pectoris major and minor muscle, no longer indicated. The removal of muscle nowadays it is being abolished due to post-op complication and not providing any benefit to the patient. Most commonly, this will be the diagrammatic representation of the structures which will be removed. The breast tissue will be removed. The lymph node status will be removed. You have to see the attachment, the positioning of the arm. Modified radical mastectomy Patty's breast with associated structure, dissected en bloc. Excision mass is composed of the whole breast, larger portion of the skin including the nipple which is centrally placed over the tumor. All the fat, fascia, lymph nodes of the axillary are removed. Modified radical mastectomy, this will be the ideally in the first diagram you can see the part which will be removed. The incision is in the third image. You can see the incision which has been provided. We have to remove the breast with entering from the axillary tail. We have to enter the axilla in which the lymph node 1 and 2 are to be removed. Pectoralis major minor muscle is either retracted or divided. Axillary vein and nerve to the serratus anterior and the latissimus dorsi are preserved. Intercostal branches nerves may usually be divided since they only provide hyperesthesia to the costal margin. After surgery, you have to always insert a drainage tube into the breast tissue so that you have performed lymphatic dissection. So, if you will place a drain in the wound, it will remove all the lymphatics which has been present which can cause recurrence or seroma formation. Wound is drained using a wide bore suction tube. Early mobilization of the arm and physiotherapy. Most patients able to resume light work and household within a few weeks after the drain has been removed. Drain has to be kept for 2 to 3 weeks. Now, conservative breast cancer surgery, also known as wide local excision, aim is to remove the tumor plus a remove. The clearance of a tumor is always 1 centimeter of the normal breast tissue and retaining the breast contour. In the first image, you can see the difference in the part which has been being removed. The whole breast is being not removed. A small portion is being removed so that the breast anatomy or contour has to be maintained. And since 1 centimeter tumor margin clearance has been obtained, this type of surgery is only done in which there is no local invasion or metastasis. In locally advanced case in which breast tissue and there is only 1 or 2 lymph node involved, you can perform it. And the tumor lies in one quadrant of the breast tissue. If there is multifocal, you can't perform breast conservative surgery. Second, if the size of the tumor is larger than the breast volume, you can't perform BCS. In your books, there is a classification given differentiating between BCS and the radical MRM. You have to learn it and it is asked in exam. Now these are the different terms which we use for removing of the breast tissue in the OT. If you go sometime, you will see it has been written in the operative procedure, lumpectomy, quadrectomy. Same type of terminology is being used in liver resection, segmentectomy, triasegmentectomy, hepatectomy. This is a lumpectomy. Lumpectomy is a benign tumor is excised, large amount of breast tissue is not resected. So it is under BCS. Quadratectomy removing the entire quadrant of the breast containing the tumor. In this, chances of BCS is less. Both the lumpectomy and quadrectomy are usually combined with axillary surgery via a separate incision. Role of axillary surgery: when you have to perform an axillary surgery, stage the patient and to treat the axilla, presence of metastasis disease with axillary lymph node, best single marker for prognosis, major determinant of proximity of the system adjuvant therapy, but treatment does not affect long-term survival. Options: what are the to dealing with the axilla? How you know what is the involvement of the axilla? First and foremost, I have told you central and lymph node biopsy, sampling, removal of the lymph node behind and lateral to the pectoralis minor, and a full axillary dissection. In the third point, removal of nodes behind and lateral to the pectoralis minor, which levels I am talking 1, 2, 3, 1, 2, 3, in which we all these are. In the previous slide, I have told you what is the relation with the pectoralis minor muscle. Sentinel lymph node, previous class I have already told you, it has been performed in 3 surgeries: CA penis, CA breast, malignant melanoma, and in some cases CA colon. Standard of care and management of the axilla. In patient with clinical nodes negative diseases, sentinel node is localized pre-operatively by the injection of patent blue dye and radioisotope albumin in the breast. This is the sentinel node biopsy which is being performed. You can see in the right side there is the gamma camera which is being used to identify where the lymph node is present. This single lymph node is excised and sent for histopath. If there is chance of metastasis involvement, then only the axillary clearance is being performed. If not, if this is negative, the axillary clearance is not done. Excised lymph node is sent for frozen section HPE to touch imprint cytology in patient with no tumor involvement of sentinel axillary dissection can be avoided. Chemotherapy and radiotherapy given to a woman with hormone receptor positive tumor. You have to remember these drugs. Tamoxifen reduces the annual rate of recurrence and death rate, reduces the risk of tumor and contralateral breast. Optimum duration of treatment is of 5 years. LHRH antagonist for premenopausal receptor positive women induces a reversible hormonal suppression, has same effect as surgical and radiation induced ovarian ablation. Oral amorphase For postmenopausal women, treatment for recurrent diseases has a shown priority over tamoxifen. So tamoxifen has a lot of side effects. Chemotherapy, what we have to do, you can remember it by the mnemonic CMF, cyclophosphamide, methotrexate, and 5-fluorouracil. 25 reduces in the risk of relapse over 15 to 10 to 15 years period, no longer considered adequate adjuvant therapy. In the modern regime, anthracycline, doxorubicin or epirubicin and taxanes can be used. Given the lymph nodes positive and lymph node negative patient with prognostic factor are present, tumor grade, size, risk of the factors. Combined hormonal and chemotherapy has additive effect. Hormonal therapy is started after completion of chemotherapy to reduce side effects. High dose chemotherapy in heavy lymph node involvement has no advantages. So in that case, you have to perform an axillary clearance by any way. Now, what is neoadjuvant? Neoadjuvant means neo, before the surgery. First thing you have to give, in which it is mostly done to shrink the tumor to enable breast conservative surgery to be performed. Successful in up to 80% of cases, and nowadays most of the oncosurgeons prioritize to give a neoadjuvant therapy before surgery. The only disadvantage, even though the tumor has been shrinked, it has caused a lot of fibrosis in the tissue. The surgery is always difficult after neoadjuvant therapy. Not associated with improved in survival compared to the conventional method. Chemotherapy route is mostly oral or IV, given in cycle. Constantly it is of 4 cycle or 6 cycles. Given a cycle, constant to the treatment period followed by a recovery phase. Number of cycles depend on the type of drug used. Not given for more than 6 months. Hormonal therapy every day for the next 5 years. These are the references which we have used, and that was the class.